Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling pericarditis. As always, let's kick it off with our practice question. A nurse is caring for a client admitted with acute pericarditis. Which assessment finding would indicate that the client is developing a cardiac tamponade and requires immediate intervention? We have a sharp chest pain that improves when sitting up and leaning forward. B, a pericardial friction rub heard at the lower left sternal border. C, blood pressure of 86/54, JVD, and muffled heart sounds. Or D, diffuse ST segment elevation on a 12-lead ECG. Think about your answer, tuck it away, make your just best guess because we will circle back to the correct answer at the end of the episode. But before we get lost in all of the symptoms and EKGs and stuff, let's dive into the anatomy and physiology. Taking it back to the basics, I want you to picture the heart as wearing a very snug double-layered jacket. And that jacket is the pericardium. The inner layer is the visceral pericardium, and it is stuck right onto the heart muscle itself. So inner lining of the jacket, boom, right there. Then because it's a double layer, the outer, that's called the parietal pericardium, is more fibrous and tough. Now, between the two layers of this jacket, we have a very thin potential space, and usually it's got about 15 to 50 milliliters of serous fluid. Basically, that fluid is just like a little lubrication between the layers so that we can let the heart move smoothly as it beats. Expands, contracts, you get it. We've got kind of some lubrication there, like a well-oiled hinge. So under normal circumstances, pericardial space is low friction movement, and we've got that protection of the double layer jacket. Basically keeps the heart from overstretching, anchors it to the mediastinum in our chest, and acts like a shock absorber. It's a protective bubble around the heart. So what goes wrong in pericarditis? The pericardial layers, that outer and inner layer of the jacket, get inflamed. Remember, itis means inflammation, pericardium's the layer around the heart, pericarditis, the pericardial layers get inflamed. You get it. Now, most commonly, this is triggered by a viral infection, post-MI inflammation. So we had a heart attack, and then afterwards, our heart's a little angry, it gets inflamed. Autoimmune conditions, it can be a trauma, or it can be a cancer, a malignancy. So multiple different ways this can happen, but something has triggered inflammation of the pericardium, pericarditis. So the local blood vessels dilate, they get leaky, plasma proteins and inflammatory cells start seeping into the pericardial space. The texture of those layers change. They're no longer smooth and glossy. Now they're rough and irritated from all these inflammatory changes, which means instead of these two layers just gliding past each other, that well-oiled hinge we talked about, now we essentially have two pieces of sandpaper rubbing up against each other. And that's happening every time the heart beats. That rubbing eventually becomes the friction rub that is our classic sign on auscultation of pericarditis. We'll talk about that in a second. But just visualize the anatomy with me for a second. Those pericardial layers get swollen. There's extra inflammatory fluid. The heart is trying to move in a space that is tight and irritated. With every expansion and contraction, we've got sandpaper sliding against each other instead of those nice smooth layers gliding without any friction. And as inflammation ramps up, all of that leaky fluid means that pericardial fluid can increase. So that amount of fluid between our two layers can go up. Sometimes this is just a little, sometimes it could be a whole lot. But even a little increase in the pericardial fluid can put a lot of pressure on the heart. The heart lives kind of in a fixed volume box, inside that double layer coat. It can't really expand past that. So if the fluid is going up and up in that pericardial sac, the available space for the heart to expand and contract is going to go down. And that is a really, really big deal. The heart needs to expand during diastole to fill with blood. Do you remember how cardiac output works? Stroke volume times heart rate is cardiac output. That's how much blood we're getting out to our body every single minute of our lives. Stroke volume is how much blood that heart can pump forward every time the heart contracts. And that's very dependent on how much blood we can actually fill the heart with. So that's why this all matters so much. In diastole, the heart has to relax and expand, fill with blood, and then it can move that blood forward. We get good stroke volume, we get good cardiac output. But if you start squeezing the heart from the outside with this fluid filling up in that pericardial space and pressing in, then it can't expand. It can't fill with blood. We have a lower stroke volume and therefore a lower cardiac output. So to keep cardiac output up, the only other thing we can do is increase the heart rate to compensate. And the body's really good at compensating, right? The sympathetic nervous system kicks in, it jacks that heart rate up, it raises the systemic vascular resistance so that we maintain our blood pressure and our perfusion. But if that fluid in between the pericardial layers keeps accumulating, the pressure in that pericardial sac will eventually surpass the pressure inside the cardiac chambers, especially during diastole. And when this happens, the heart is literally just being squeezed by its own fluid-filled jacket. This is the complication of cardiac tamponade, external compression of the heart leading to severely impaired filling and therefore a dramatic drop in cardiac output. So summarizing up until this point, we had some sort of trigger. The pericardial layers of the heart got inflamed and mad. Now, instead of smoothly sliding, they're like rough sandpaper. All that inflammation is causing more fluid to go into that pericardial sac. It's pressing down on the heart, making it real hard for the heart to expand with diastole and fill with blood. Less venous return means less stroke volume, means less cardiac output, and then our heart rate is going up to compensate. This is kind of the spiral, the domino effect of pericarditis leading into cardiac tamponade, which, as you could guess, is absolutely life-threatening. So let's paint that picture walking through a little scenario here. This story that I've got for you today is from a step-down unit, a client who really probably should have been in the ICU, but a 52-year-old man. He came in from the ED where he originally came in for chest pain. So everyone was thinking MI, he had gotten a 12 lead. His story was a little bit interesting though. About a week prior, he had been sick. He was like, I had the flu, low-grade fever, body aches, chills, etc. But then he bounced back. He went back to work. And 2 days before he came into the ED, he started feeling this sharp pain in the center of his chest, actually, and really high up. Sometimes when people point lower down, I worry about GERD or indigestion, but he was pointing like up here, like really high was where he said he had this pain, and he said he had had it for 2 days. Nothing acutely wrong in the ED, which is why he ended up coming to the step down. His vitals were stable. His oxygen was like 98% on room air. But as I was kind of alluding to, what really caught my eye was more how he was describing the pain. When I think MI, I think heavy crushing pain. And he was using the words sharp and stabbing. He also told me it got worse when he took a deep breath, worse when he coughed, and worse when he lay flat. When he was sitting up and leaning forward, he was like, this is the most comfortable position. The pain maybe like eases off a little bit. So I just want to kind of recap how he was describing this. These are all big buzzwords for pericarditis. The pain that he's describing is pleuritic and positional. So what I mean by that, first, positional, you probably totally get. When we lay down, that pericardial fluid that's accumulating is pressing on our heart. Gravity's working against us. The pain's going to be worse. We sit up and lean over, kind of in that orthopnic position, is when it eases off. So that positional pain made me think more pericarditis versus MI. And then the way he described it is being pleuritic, sharp, stabbing, and worse with a deep breath coughing. Those are kind of classic indicators that when we're increasing that intrathoracic pressure with a deep breath or coughing, the pain is worse because we're putting more pressure on that pericardium, and it classically feels sharp and stabbing. Okay, so that's kind of like the qualitative descriptors, etc., things that should maybe catch your eye. As I said, his vitals weren't terrible. This was not like he's coding, he needs to go to the ICU. He was mildly tachy, slightly elevated temp, BP was borderline normal. What caught my eye wasn't the vitals, it was the auscultation. He had a clear as day pericardial friction rub. So as soon as I put my stethoscope on his chest, I could hear a scratchy, I would maybe even call it like a leathery sound with every single heartbeat, kind of at the lower left sternal border. It's not a murmur, it's not breath sounds. It is those two layers of the pericardium, those pericardial layers that are literally acting like sandpaper, rubbing against each other with every contraction. So every heartbeat, it's kind of like a little scratchy, okay? All right, so even though his vitals are stable, these assessment findings and the way he's describing his pain are enough to make us, think we need to do something else. What else do we need to do as nurses? What do you think? What is your next step if this is your client? We need some diagnostics, right? Put them on the monitor. Let's get a 12 lead. They had actually already done that in the ED for us. And we need to get some labs, all right? We're going to draw a bunch of different things so that we can see what is going on. So the EKG that my friends in the ED had done, it did show some ST segment elevation. It also showed some PR depression. It was across multiple leads, so it wasn't like localized like we would see in an MI. It was more global. The heart's not happy. Something's a little funky. And let me be clear, this was very mild. It was not a super alarming EKG. Labs were much more alarming to me. I will say importantly that his troponin was minimally bumped, but not super high. It wasn't like, oh my gosh, his heart cells are dying. He's ischemic. It was like a tiny little amount of troponin. It did show what you would expect to see with pericarditis, massively increased inflammatory markers. His CRP, that's C-reactive protein, was through the roof, as well as his ESR, that erythrocyte sedimentation rate. Those are kind of the two quick check inflammatory markers that we're going to grab. They're not really good at giving us any sort of specific diagnosis, but they do just tell us overall, is the body inflamed or not? And his body was super inflamed. So seeing high inflammatory markers, but just like a really low troponin makes me think this is more inflammation, not infarction. So this is all pointing towards a pericarditis, but it is not diagnostic. Like I said, inflammatory markers are really broad. The EKG is really broad. What can actually tell us definitively this is pericarditis? We have to do an echo. So the cardiologist came to the bedside, grabbed his probe, did a bedside echo, and he was able to visualize that there was extra fluid around the heart. Given that, paired with his history of being sick about a week ago, the official diagnosis was acute viral pericarditis. He had gotten sick. He said he had had the flu. That triggered an inflammatory response. His pericardial layers got really rough and irritated. That's why they were rubbing like sandpaper and why I could hear that friction rub. And all of that fluid kind of leaking into the pericardial space was starting to press in on the heart. That was causing the chest pain. That's why it was worse laying down and better sitting up. That kind of explains all of the symptoms he was having. So what do we do about it? What is our nursing plan? We've got our diagnosis. We are focusing on pain control, monitoring for complications, and supporting the medical therapy. So first, he was started on high-dose NSAIDs. This helped calm the inflammation, all right? At the root here, we got pericarditis, itis, inflammation. We need to get the inflammation down. NSAIDs are really good about that. We also want to position him in a position of comfort. So upright, leaning forward, that orthopnic position is really, really good. That mechanically like takes a little pressure off our inflamed pericardium. So get him nice and comfy, lots of pillows propped up. Monitor those pain, vitals, telemetry, and watch really careful for any complication. What is the complication I'm most worried about? What we talked about in our A&P section, that inflammation will lead to more fluid going into that pericardial space, and that more fluid will press on the heart, constrict that heart's ability to expand and contract. It'll drive the stroke volume down, the cardiac output down, and we will go into cardiac tamponade. That is like the worst case, scariest outcome here. And it did not happen for this gentleman. He came in early enough. We identified it quickly enough. He did not need to be escalated to the ICU. We were able, with NSAIDs, to calm that inflammation and let that resolve over time as he recovered from the acute viral pericarditis. But what would it look like if we were going into tamponade? Okay. Let's say, the next day I came back, I walked into the room and his color was off. He looked a little dusky, maybe around his lips starting to get a little blue. He's like, I feel weird. I feel lightheaded. BP dropping. Previously normal, like 120 systolic. Now it's in the 90s or 80s. Heart rate going up, climbing to be more and more tachycardic. What else would we see that tells us we're going into cardiac tamponade? Think about it. Think about the physiology. We're squeezing in on the heart here. So we're not really getting good venous return. And that blood is up in the neck veins, distended neck veins, our jugular venous distension, or JVD. That's a big red flag for cardiac tamponade. Another big red flag, when you go and listen to that heart, you might not hear a friction rub anymore. You might now hear muffled heart sounds because that fluid has accumulated so much that it is now dampening the sound of our heart. Nursing interventions will need to move very quickly. Place them on oxygen to maximize the amount of cardiac output that they still have. Keep that head of the bed elevated to reduce venous return and prevent further overload. Monitor mental status, urine output, and BP, all those indicators of cardiac output, and get ready for definitive treatment, which is an emergent pericardiocentesis. This is a procedure where the cardiologist takes a needle, puts it through the chest wall into the pericardial space, and attaches it to a drainage system. We need to drain, whatever excess fluid is there, and that's going to stop the heart from being squeezed or compressed so that it actually can relax and fill and then get that blood out. The results of a pericardiocentesis, this is really one of the coolest things I feel like I've gotten to see at the bedside, because you can see hemodynamics in real time. Like as that extra fluid comes out of the pericardial space, blood pressure goes up, heart rate eases down because we don't have to compensate as much. Like you are watching cardiac output improve in real time. Their color gets better, their pulse gets stronger, cap refill comes out, the JVD goes down, all those symptoms like dizziness, mental status changes, they start getting blood everywhere again because the heart's not compressed, and you get to really watch in real time like how that patho plays out. So again, for my story, for my gentleman that came in with pericarditis, he luckily did not progress to a cardiac tamponade, but I wanted to throw in what that would look like because that is the most serious complication that I think you all need to make sure you know the warning signs for, so you're always monitoring for it. And with that being said, it brings us right back to our practice question. So bring that answer back out. Let's review it and see now if you can get to the right answer and understand why. You're caring for a client admitted with acute pericarditis. Which of these assessment findings would indicate that they're developing a cardiac tamponade and it requires immediate intervention? We had A, sharp chest pain that improves with sitting up and leaning forward. B, a pericardial friction rub heard at the left lower sternal border. C, a BP of 86/54, JVD and muffled heart sounds. Or D, diffuse ST segment elevation on their 12-lead ECG. So which finding would indicate tamponade and therefore require immediate intervention. If you said C, that BP of 86 or 54, JVD and muffled heart sounds, you are correct. That is the classic trio. It actually does have a name. It's called Beck's triad, which points to tamponade. It tells you that the pericardial fluid has built up enough pressure to significantly impact cardiac filling. And therefore, we can't get blood in, we can't get blood out, and cardiac output is going down. It's an emergency, and we need a pericardiocentesis. Our other answer choices: A, that sharp pain that's better sitting up and leaning forward; B, the pericardial friction rub; and D, the diffuse ST segment elevation. These are all things that we can see with pericarditis. I would expect these findings in acute pericarditis, just like we saw with our client on the step-down unit. But none of those tell me that we're moving forward into tamponade, so they do not indicate that complication or the need for emergent intervention. So your key takeaway here to wrap all this up: pericarditis happens when the heart gets inflamed and those layers start rubbing against each other. You're going to hear a pericardial friction rub, and you might find pleuritic chest pain that's really sharp and stabbing. Now, the biggest red flag to watch out for is the progression to cardiac tamponade. So I need you to remember Beck's triad. Those 3 symptoms that put together tell us we are progressing to tamponade. They are hypotension, JVD, and muffled heart sounds. If you see those 3 together, you need to urgently escalate it to a provider, because the treatment for cardiac tamponade is a pericardiocentesis. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.